Okay, good morning everybody. It's me again. Dent 11:59 Friday morning. A little bit not exactly ideal with the video, but until we get both rooms straightened out, it may even be straightened out today. But what I will do is when we get to the demonstration part of the program, I'll demonstrate again in one room and I'll demonstrate in the other. Or Carrie and Musa can do that, and Ashley. And then if you need any help, bring it to the front. But I do have another video after this of the demonstration as well, but not the upper and lower. So once again, this is full, complete prosthodontics, a very busy class, Friday, 8 hours, 15 weeks. 5 sets, upper and lower. Hopefully 6, but I think 5. You will get a rubrics outline, which will have every project, custom tray, occlusion rim, setup, wax up, invest, trim, polish. We're going to do 5 scenarios. We'll do a class 1, a class 2, a class 3, a lingualized occlusion, and then number 5 is an immediate denture. Number 6 is the implant denture, which one day I'd like to move into the full denture class, but for now we'll leave that in the implant part of the program for third year, sixth semester, third year. So that's 5 sets, class 1, class 2, class 3, 0 degree class 3, teeth, lingualized occlusion, and immediate denture. Let me go over the outline quickly, and then we'll talk about today's first subject. I was a little long on Wednesday, so I'll try to keep it a little bit more brief, so we can spend more time developing our skills, which I think we all need that time, since we have so much work to do. So quickly here, week 1, orientation, pour pucks. We've poured the models for you already. They're in the tray, ready to go. The protocol we were getting somewhat familiar with coming in and out of the building, change rooms. Consequences of tooth loss, anatomy, and steps of complete denture fabrication, and more importantly, preliminary impressions today. There it is, preliminary impressions and custom trays. Custom trays are worth roughly 2% of the practical of each project, and I think it's the first week. We'll start off slow, but not too slow, and try to get these trays done today, and then even move on to the occlusion rims, which will be due next week, but if they're done this week, that's fine. So it's not a race, but as soon as your work is ready to be evaluated, let's do that and move on. Don't get stuck at the evaluation and say, well, I'm not going to move on to the next step unless I get a 10. If it is really atrocious and needs some work, we'll send you back. But if it's something close with some minor things, let's check it off and move on to the next and get better with each project, rather than making a career out of the first week's custom trays for 3 weeks. We've got only 15 weeks together. And you can go through the outline. I think the project's weighting is 60% and the theory is 40%. You can see midterm week 7 is a 20% theory, 50 multiple choice questions, and then another 20% on week 15, 50 multiple choice questions on final dentures. Is it enough questions on full is it enough questions on full dentures? No. But as second year, I think we're gonna cover a lot of ground. We're gonna cover the history. We're gonna cover the occlusal philosophies in full denture construction. Hildebrand, Gerber, and another 6 out of that textbook. The removal prosthodontics that you've all purchased for partial dentures are the same. Chapter 8, full dentures in that. We will be covering those. Dr. Haller et al. So there's the outline. Any questions? It's on your blackboard. Thank you, Carrie, who posted it up there for me. I believe she put that up there Wednesday. And the videos from Wednesday, you can click on links, which I think is useful if you need to go back and you have something set up at home where you want to, do something. But if you could do all the work in the classroom, we have more than enough time. If I stop talking for hours, I think you'll have more time. So I promised I would do that. So let's move on to our first picture of preliminary impressions. So the patient's going to come into the dental office. They're presenting with no teeth. They're completely edentulous. And this is a review from last year, the anatomy, which I'll go over again, which will have a diagram in our, we also get a full denture handbook that we photocopied. You'll get today. We can go page by page, especially through the anatomy section to review. And the preliminary impression is usually a stock tray and alginate that the practitioner is going to use to capture all the anatomy, expanding all the tissues. So the preliminary impression is unfortunately used as a final impression a lot these days, which it should not be. But the whole idea is to capture all the anatomy, kind of expand all the tissues here of the attached and detached mucosa, internal oblique ridge, lingual frenum, retromolar pad, buccal shelf, buccal frenum, labial frenum. I think I got most of them unless I missed something on the lower. So we need to take an impression of everything, which you will receive that model today, and then we'll outline again where we think the border is, and with a spacer on our model, we'll create the custom tray like here. Now that spacer, how much wax is the spacer? If it's no undercuts, it can be a thin film. If there's a lot of undercuts, we don't want the tray binding, especially on the internal oblique ridge or in the lower lingual. The tray needs not to bind on the tissue with a final impression. Depending on the material we use, like I said in the video, polyether could be thinner. Usually these days it's a PVS. And if they're border molding in a compound, or are they border molding in the heavy body? We'll discuss this at the demonstration of the custom tray video. So this is a client, one of the clients of mine. I'm trying to get the expander in there to take a picture, but you can see how that tongue through tooth loss just falls into the neutral zone. The cheeks fall in on top of the ridge, the tongue falls over the ridge. We talked last year, I'm sure you did with Mr. McCormick, about atrophy of the ridges. Now, the mandible will atrophy probably 2 times quicker than the maxilla due to the composition of the bone. Lower mandible has some cancellous bone with a cortical plate on both sides, which is subsequent to more atrophy, where the upper part of the skull is more cortical bone, and with the palate, the atrophy is a lot less or slower. But this is all dependent on many things. Is it a male? Is it a female? The age? Is there systemic problems health-wise with the client? 5, 6 reasons why some people will, genetics, their atrophy of their edentulous ridges quicker than the others. And then also ill-fitting dentures will increase atrophy of the ridge as well. Ill-fitting dentures are banging on top of those structures, causing them to kind of recede. A good fitting denture can actually stimulate some osteoblastic activity and create some bone or maintain bone level. But like I said, age of the patient, male, female. Females get a bad rap here, especially if we're into the menopause years where we've got lower estrogen levels, calcium depletion, osteoporosis. These ridges are atrophying at a quicker rate. But nevertheless, you're concerned with making something. Dentists take a preliminary impression, we pour the model. They want a custom tray to better capture the attached and detached mucosa borders with a higher detailed impression of the ridges that we will then go and create the occlusion rim for all those bite registrations, midline, canine line, vertical dimension of rest protrusive centric relation records, Facebook records, and we'll go through each of those again that we discussed the other day. Upper maxillary anatomy, tuberosities, mid-palatine suture, rugae, incisive papilla, labial frenum, buccal frenum, buccal shelf, palate. We'll give you a diagram and identify these. We're going to get our models and we're going to identify them with our pencil on our models and do some model analysis, which would, 5 minutes. There's a stock tray. It's an edentulous stock tray. Most dentists will use a dentate one, but an edentulous one. And it's a little short on the internal oblique ridge, so I've added some periphery wax to kind of, cheat a little bit, extend the borders to support the alginate on the lingual side. Ask the patient, hopefully they lifted their tongue up side to side, and so we could capture below and inside the tongue. We do the upper one the same way. Now you're not taking impressions, but you need to see what's going on. And there is not a great impression, but I think it captures enough to make a maxillary occlusion rim. We pour it up in stone, wax spacer, and then make the tray. Here's the upper impression again. A little saliva voids and maybe not as detailed in the labial frenum area. But I think that's enough to go ahead and make a custom tray. There's the lower one. You can see the extension of the internal or lower lingual frenum, lower lingual sulcus, internal oblique ridge, myohyoid ridge. You can see that has to be captured. Now, will the denture fully engage down there? It'd be nice if the patient could tolerate it, but if they can't tolerate it, we've got to shorten the flange. But without a picture of that depth, then the denture doesn't have a chance of getting down there. But obviously, the more landmarks that your denture can cover, the more stability in the denture itself. So if we're missing key elements of the anatomy and they're not covering them and they're shortened, which I'll show other pictures of that, then that would be short of ideal. And here's the lower, enough to make a custom tray. So we need to kind of guesstimate where the attached and detached mucosa is. You can see my cursor here. We're going to draw a line on our model and maybe be slightly short of those deflections. Now, Mr. McCormick last year might have said, well, 2 millimeters short of the sulcus. But regardless, I just want you to make the tray to where you think it's going to finish. And if err anywhere, you can err on the short side. Because that tray will be lifted up with some stops. And then, depending on how the practitioner inserts into the mouth or how thick the material is, they could bottom out the tray onto the ridge, or they could leave it 10 millimeters off the ridge. So your length is really immaterial, but it should follow the same contour pretty close with a average spacer, of maybe a sheet of wax. Sometimes 2-3 sheets of wax. If there's undercut, like in this area on the lower lingual frenum, that'll be a lot of wax there. Oops. We turned color here. There we go. And here's some spacer wax. You can see on the upper, I just put a thin shim. I think for this case we're doing here in Project 1, I would do a lot thicker, especially around the labial frenum. I have some samples I'll put on the document camera in front of each classroom that you can have a look at. Just kindly leave them at the front. Don't take them to your desk so people will be able to see them on the screen. And then on the one on the right there, the lower, I did a little bit more. Now you see the eclipse stuff in the background. That's not so popular anymore, where it was a processed denture base before the teeth. We're going to make those spacers and we're going to make those custom trays today. And you're going to light cure, but something in this picture that should be better than the one I'm doing here is that handle should be no more than 10 degrees in the anterior. You'll see in the demonstration I didn't create one so angled, because we don't want that to deflect the upper lip, the orbicularis oris, the labial frenum, or under the nose. We want to be able to bring that upper lip over and down above the tray to get not only the length of the border, but also the width of the border. We always talk about how long the denture is. We need to know how wide the denture is as well, how wide the border that is. You know, how thick the border. We just don't guess with the burr. And here I'm using the Enter LightCure. And there's 2 trays. Unfortunate, those handles should have been more up and down. But there's no perforations in the full denture tray. And then here's what I'm talking about. That tray is used for compound stops or heavy body silicone stops. So you can see I've put 3 areas of heavy body in the tray and put it in the patient's mouth. How thick and was my impression going to be? You can see here at the side, about that thick. Now I could have made that thicker, I could have made it thinner. So this tray had no tissue stops like you may have created last year. I made the tissue stops out of silicone and a compound or compound. I do them both ways. But here I'm showing a silicone. And then, now that I've got basically the tray lifted off the patient's mouth with this much space, this will be a static position of the tray in the patient's mouth. Then I'll go around and do the border molding with whatever material I choose. Obviously something rigid and something accurate. Let's see what I used here. Well, I'm using a heavy body, which is can work, but I need an assistant to retract the upper lip so it doesn't drape down. So I'm injecting the heavy body on both sides. You can see the labial frenum even has injury from the old denture not being relieved. I can see a bit of it there. And then I'm border molding the upper lip, bringing it up and over the tray. That handle's kind of interfering, but I think you get the idea. And then moving the cheeks down and over and wide, kind of exaggerating some facial movements of expression. And you can see now my border is deflected. Now this is a good picture. You can see the detached mucosa that I'm stretching out, which may have been stretched in an alginate. But you can also see the heavy body is been deflected down to that facial expression move that I made. So there's going to be the extent of the denture. If we didn't go through these procedures, dentures will be overextended or underextended, or luckily at the right place, guessed. And the patient's, it's all about adhesion and suction of the complete upper denture onto the ridge with the type of saliva we're going to talk about later that'll create this adhesion of the upper denture, but also this trapping of air all the way around creates this adhesive suction that's going to maintain that upper denture in place. Yeah, you can see again the injurious incisive papilla from the old denture should have been relieved. And prior to taking final impressions, it would have been advantageous to have that heal first. And now you can see the borders done in heavy body. Now it looks different than the preliminary impression, doesn't it? You can see the frenum now on the left side, how deep it is. And I'm basically almost taking an impression with the heavy body. Once the border molding is done in the soft palate or the post-dam, or the posterior area of the denture, I'm going to take out those heavy body things and take another impression inside, or I could take a light body wash over everything. Careful not to drop the tray and extend the borders with another thick material. So hopefully a very thin wash. You can see the detail of the border. I need to pick up here in the hamular notch, looks pretty crappy, but we can fix that up. But I think what I'm trying to show you is this is nice here. There's the frenum, there's the extension of the denture. So now when I go to make my occlusion rim waxed border is exactly that border. There's no 1 millimeter short, long guessing, no guesswork, right to the end. Now in this first case, we're going through semantics where you're going to make the occlusion rim on the same model. I'm not sure if we poured 2 sets, but I think, we'll be quick. I'll evaluate your custom tray and then you can make the occlusion rim. And we'll get moving. Oh, I did it again. Now there's the border again. So here I've elected to take out the stops and I'm going to use the same homogeneous material back into the patient, hopefully not extending those borders. And will be the final impression. Now I'm going to do a second one where I'm going to load the tray all at once. and the borders. I'm doing it all in one shot. So that's the second way of doing it, all in one procedure. It must not have turned out, or I would have showed you the picture, I guess. I'm not sure why it's not there. But here's the same tray with 3 compound stops instead of the heavy body. And then compound border molding, done sequentially of each quadrant or a section of the quadrant. And there's the final impression with the compound underneath. You can see it just poking through. So I've taken 3 different types of impressions here with the patient. I did a heavy body border with a heavy body after. I did it all at once. And then here I did compound borders with a medium body final impression. Each practitioner will do something different. Your job is to make the custom tray. Here's another final impression of that freedom area. And here, we'll just omit this, but I'm making a processed base plate, heat light cured, to make my occlusion rim on. We're going to make ours out of light cure, but not this tight, not as a final product. Ours are temporary that we boil out. This will be part of the denture base. So here's the lower. It looks like I did a medium body with a light body wash on top and tried my best, which is very difficult to border mold the lower, especially if I was taking pictures in a one-man show. I needed it could be a little bit better here, I think. But nevertheless, all the anatomy is captured, and the idea is to get the border of the attached and detached mucosa exact. So when we make our denture, there's no guesswork at the length and the width of the borders. No guesswork at all. I've poured the final impressions from my custom trays, and now I'm making occlusion rims. This will be second part of project 1 today. Now, I'll go over the anatomy in each class again, but like I said, I don't want to go on from last year and review all that anatomy for 2 hours and waste our valuable laboratory time that we all came here for, which I was guilty of the other day. So my apologies if you felt pushed on the partial denture occlusion rim class. But I think everyone handed in and did really well. But I want you to spend more time and get really good with the wax. If you leave George Brown with any skill at all, which I'm sure you will, at least you'll be great occlusion rim manufacturers. So when you get a job in the laboratory, they'll say, oh, those are nice occlusion rims. That'll be your first job. You can make them all day long. But here I used maybe a clear base plate on the upper, but nevertheless, you'll be using a pink one. Now, 8 to 10 in the posterior, 3 to 5 in the anterior. Mine's a little thick. 8 to 10 all the way around on the lower. Make sure you trim your models parallel to the occlusion. Now the occlusion of the lower rim is 18 millimeters, that's an estimation, and 22 for the maxillary, for a total of 40 millimeters of average vertical dimension. That is the starting point for the practitioner to evaluate the vertical dimension first and foremost during the bite registration stages, which I'll show you next week or the week after when we get to that stage of taking bite registrations. Now this program, we've pre-mounted all the cases on semi-adjustable articulators. Those articulators will be simulated patients. We got 3, 4 of them here for the 2 classrooms. And when your occlusion rims are adequate, you'll come to the front, and Ashley, myself, or Carrie, or Musa will establish and give you the centric relation record. Midline, canine line, a smile line. You will therefore go back with the procedures to follow. We'll mount the models on your semi-adjustable articulator, which we need to talk about, and then proceed to the setup for trying. Big mouthful, but you know what? Let's not wait too long. But here you can see the occlusion rims. I've taken out here, my base plate only goes to the lingual part of the maxillary ridge. The base plate is not a finished product. The base plate is just a strengthener of the maxillary occlusion rim. This will get boiled out, thrown in the garbage when we go to process. But right now I need something rigid that's not going to be, falling apart in the patient's mouth. If I went all the way around to the sulcus, that's fine, like you did last year on most of your projects. But what happens is, I know from experience, when I go to set up teeth 3, 2, 1, 1, 1, 2, 3, that I'm going to be hitting the ridge. So therefore, I've seen many students, especially down the hall there, they're trimming the teeth short, just so it'll fit on the tray. But then the patient smiles, and we've lost the vertical length of the denture teeth. It doesn't look as natural. So I want these denture teeth, in some cases, they may be right on the ridge, especially in our immediate denture case, Project 5. The teeth will be right on the ridge here. So I don't want any base plate in the way, and I don't want to be trimming base plate while I'm setting up the teeth. So I just assumed I took it out of the way. On the lower, I took it away from the borders, so if there any adjustment, chair side, I can adjust the wax border. Make your wax border on your occlusion rims equidistant. So if it's 3 millimeters here, it's not 6 and 4 and 2. It's 3 millimeters all the way around. Be consistent. So therefore, your light cure base plate tray would be, you spend some time keeping it short of the deflections. Again, don't forget when you're making your occlusion rims, Vaseline for the light cure, soak the model in water, I think is adequate for a good length of time before flowing hot molten wax into the borders. If your model is wet and you're blocking out for the custom tray, be careful it doesn't come off. So the model will probably be dry to do spacer for the custom tray first, which you'll boil off after, and then proceed to make your light cure base plate trays for the occlusion rims. A lot here to think about, but this is review. Once the occlusion rims are made, this will be our first step of bite registration. Once it goes to the practitioner, what do they do with your occlusion rims? Well, the maxillary is put in first to establish the plane of occlusion, number one. And this is the plane of occlusion, which is parallel to something called Camper's plane, or the allotragus line, which is a line parallel to the occlusion, imaginary line, from the ala of the nose to the tragus of the ear. We could get a pencil and draw it on the gentleman's face, but you can see this fox plane, which is up against the occlusal plane of my rim, is parallel to the allotragus line, establishing this horizontal plane of occlusion. So it's not drop to the left, drop to the right. This is the very most important, very first thing you should do with the occlusion rim. Establish the plane of occlusion, and then the vertical dimension of the occlusion at the same time. Is it down here? It's still parallel to the allotragus line, but are the teeth going to be longer? We'll talk about what the practitioner should do, going through some exercises of how much tooth they want to show. Obviously, the younger the patient, they're going to show more teeth. The older the patient, they'll show less teeth. You know, people's elasticity of their lips are differently. Their smile lines are different. When they smile, how high it lifts, right? But also, that occlusion rim has the right labial contour. It's not like they've got a big cotton roll under their upper lip. So we have to get the contour, the plane of occlusion, the vertical dimension. The occlusion rim on the lower is not even in position in this picture. It's not here at all. It's just the upper occlusion rim first. The lower we'll introduce after and establish that vertical dimension. Now, naturally, the plane of the lower rim will be that of the upper that we've established. So the practitioner will contour the lower rim to match the upper rim, which they've adjusted to this allotragus line, or parallel to the allotragus line from the side and the front too. This kind of fox bow, or excuse me, fox plane will assist in the practitioner, and hopefully your practitioner owns the fox plane. So that was kind of quick summation of the preliminary impressions and final impressions. Let's go really quickly now. Really quickly. Where is my... oh, I lost it, but just bear with me. This is so realistic, right? 2020, 59, 21. Okay. And like I said, thanks to Carrie, because she's so awesome. More often than not, she'll post this for us. And week one, here's the edentulous anatomy. This is review, so I'm going to be really quick. There's a lot of words here, but we can see here that to properly construct the denture, the anatomy has to be understood with the edentulous patient, of the muscle mastication and the facial expression, how the tongue works. You can see the frenums exposed on the upper and on the lower, the keratinized tissue, meaning the tissue starts to defend itself, like a callus on your hand, starts to defend itself from the abrasion of the denture. You can see a good keratinized tissue ridge is excellent for denture. So the dentist will notify the client of, ridge height, bone height, obviously, or bone quality, tissue quality. Is it mobile or is it taut? Is it keratinized? The quality of saliva. All these things together, the dentist is going to come up with a prognosis of these dentures for the patient. Our job, however, is the same all the time. We're going to do the best we can. Sorry, I had a battery. I don't know how long that was there, but typical. So we need to know, this is just what I said, the muscle attachments, the type of bone, the bone quality, the attached versus unattached mucosa. These are factors affecting retention, stability, and support of the patient. Buccal frenum, the buccal vestibule, the labial frenum, incisive papilla, the canine eminence. I mean, I'm just looking at the pictures with the arrows. You can read exactly where they are, but this is a review from last year, so I'm going to be quick. If it's not review and you forgot and you just memorize some of the terms, then we're going to have to go over them a little bit more. Posterior palatal seal, I think I saw in the previous slide, and the tuberosity. Hamular notch, ruga. I mean, the ruga is like a second area of support for the upper denture. And the hamular notch, we will not extend our denture onto the hamular notch whatsoever at all. Here's ideal maxillary ridge, things I just mentioned earlier. How much keratinized tissue, square arch, palatal U-shaped cross-section. These are ideal things. A moderate palatal vault, no undercuts, no bony undercuts at least. That's going to be painful. High frenum attachments and well-defined tuberosities in the hamular notch area. Here's some good model analysis on the top left. We don't have to draw those muscle attachments, but you can see where those attachments are inserted there. Lateral pterygoid, buccinator, masseter, digastric or myohyoid on the lingual. These muscles, if we're sitting on top of these attachments, the detached mucosa, if the denture is sitting on these attachments, like the labial frenum on the right, the denture will spring or bounce or reflect out of the patient's mouth, become mobile, unstable. It's causing a lot of sore spots as well and discomfort. So this is the whole idea about why we make the custom tray, so we can get those deflections appropriately. Mentalis muscle, kind of important on the front here. How far down? I mean, if we're impinging on this, we could a patient's going to experience almost like some paralysis, because you got to remember that we have the mental foramen coming out of the front, both sides, and nerve endings and blood supply coming out of that foramen. The mental foramen, actually, on top of the mentalis muscle. So you need to go back to anatomy class a little bit and brush up on some of these things, but more importantly, you can see that beautiful diagram on the left talking about those muscle attachments that are deflected in the border of the custom tray or the denture base. The primary support is that buccal ridge. That's the primary area for the lower support of the denture, that buccal ridge, so it's got to be there. And here's an excellent border molded impression where there's no guesswork on the border extensions. I don't know what's with Mr. Battery. External oblique ridge. This is just anatomy again. There it is, kind of detailed on there. You have this PowerPoint. You want to go over the drawings, or you want to go over the picture slowly, go right ahead. You can see the resorption of the mandible, where the teeth are in relation to that buccal shell. And now look where the ridge is in relation to it in severe resorption in the bottom right. Here's the mental foramen I told you about, the mandibular canal. with the inferior alveolar nerve that comes out of there. It occupies a lot of the nerves that are coming out there. But the biggest reason I lost my train of thought. But the biggest thing here is when if you can see that it's not anywhere near the occlusion when you are a dentate occlusion on the top left. But as resorption occurs or atrophy occurs, that foramen almost becomes on top of the ridge. So now the denture is sitting on top of the ridge, and you've heard a lot of things out there in the marketplace, implants, to get pressure off there above it, or soft liners that people are advocating for this type of pain, the compression of the mental foramen. Lingual freedom, we don't want that overextension. Retromolar pad, which remains constant, it doesn't atrophy, it stays at the same height. And that's why we can use that as a reference point for our occlusion rooms of 2/3, as we did last year. Junior tubercles, lingual freedom, we need to stay off that with any kind of denture base. Here we've got the suprahyoid muscles of the internal oblique ridge, digastric, styohyoid, myohyoid, geniohyoid, the 4 muscles of the floor of the mouth are very important. That this denture is not overextended into the lingual borders, that'll just bounce right out of the patient's mouth, or they lift their tongue and the denture lifts with it. And you can see the problem with this under severe resorption if that ridge becomes higher than the ridge. And now the denture is sitting on top of that sharp ridge, and that could be kind of a painful or obtrusive obstruction to the denture. And all these things will be pointed out to the patient, hopefully by the practitioner, and they'll develop a prognosis of the dentures that they're going to receive. Unfortunately, people wear dentures and they think dentures are dentures. They oh, my neighbor has great dentures. They haven't had a problem. Why am I having so many problems? Every case is different. The bite, the vertical, the age, the atrophy, the bone quality, the saliva quality. Our job as a technician, as we said, is to do the best we can with what we have, make the trays appropriate, make the rims easier for the dentist to operate with, and that's what we're going to work on today for the rest of the day. Here's our myohyoid ridge, and you can see my alginate on the top right, or how sharp it is on the top left. And that's a bony, very tough to engage that. You don't want the denture base going underneath that. Abrading that would be very painful for the client. And here's an ideal mandible ridge. It's got good retromolar pads, a flat ridge and a deep lingual space for stability, and no undercuts and low frenum attachments. Sometimes the frenum attachments are so strong they may go for surgery and have like frenectomies or some alveolar plasty or kind of reshaping of the mandible. But these are really, obtrusive surgeries, but ideal for creating ideal denture base. I mean, that impression on the top left with the land area is excellent. No guesswork at where the extensions of that denture are going to be. And here we've got, note the varying degree of reach and width of the height. Not all mandibles are the same. Bony, keratinized, not keratinized, undercut. I mean, different scenarios. So you've got the 2 models in front of you. We'll queue up the video after break here for the construction of the custom trays to start. I'll have samples at the front on each side. We should have some. If not, I'll create new samples with a demonstration in one room or the other. Or if Carrie or Moose or Ashley feels inclined, they could bang one out quickly too. But I may want to come over because I missed the other half. A little bit brief, a little bit quick, but like I said, no stories, because I don't think the stories are going to help you on the lab side. I mean, it's only taken me 25 years to figure that out, but we really need to concentrate on our hand skills, laboratory skills, and become functioning dental technicians. Okay, thanks guys. Enjoy the break and we'll queue up the next one.